Namaskar and welcome back. This is our last lecture of week 1 of our course on rehabilitation of sports injuries of the knee. Thus far, we have already learned about various soft tissue injuries of the knee, the mechanisms that cause them, how these injuries present clinically, how they are evaluated by history and physical examination, and finally, how they are confirmed by various investigations. Once the diagnosis is established, they need to be managed appropriately. The management of knee injuries, or for that matter, any injury a person may sustain, is dictated by the nature and severity of the injuries and also by the expectations and aspirations of the patient, be it a sportsman or a sedentary individual. The patient may initially present to us with either a pure soft tissue injury of the knee, or a bony injury of the knee, or a combined injury. And this will be established during our initial evaluation. Once a diagnosis is established, we need to prioritize the treatment. The importance of life over the limb, over the joint needs to be understood. So, the first step will be resuscitation of the patient if he is severely injured. At this stage, if you find that there is a vascular injury, that is addressed on priority as an emergency. Next comes the importance of bony stabilization. It is important to stabilize the bone because it provides the framework for soft tissue healing. And finally, comes the role of soft tissue or ligament injury management. If the patient presents to us with an acute or a fresh injury, the first thing that is needed is a good first aid. For the first aid, we generally follow the PRICE principle, which stands for protect, rest, ice, compress, and elevate. In addition, analgesia is invariably required for pain. It is better to limit the use of non-steroidal anti-inflammatory drugs to the bare minimum as they also interfere in healing process. So generally paracetamol or tramadol are preferable to drugs like diclofenac or ibuprofen. For protected weight bearing, one may use crutches or walking sticks, and these are required whenever the patient has either severe pain or instability of the knee. Most often, some form of bracing with functional braces or immobilization is also required. Let's see how bracing and immobilization helps in knee injuries. Bracing or immobilization stabilize the injured knee and protect it from movements that could worsen the damage. They promote normal range of movement while preventing abnormal movements like overextension, twisting, or side-to-side movements that could stress a healing tissue. They also reduce discomfort and pain which is caused by the movement by keeping the joint still and supported. Some braces like sleeves provide compression, and that helps in controlling the swelling. They promote healing by maintaining the alignment, especially in cases of fractures or avulsions. In these situations, generally, a cast or a rigid immobilizer is used. They also help by creating a stable environment, and these devices allow damaged ligaments, tendons, or other soft tissues to regenerate without being disrupted because of the movement. And they allow controlled or protective range of motion, which is essential for preventing the joint stiffness and muscle atrophy. Then finally, they also provide a person a sense of security and confidence, allowing them to begin walking while the tissues are still healing. This next slide shows the commonest orthoses and splints used in the injuries. The first one is the range of motion brace is used to control range of flexion extension in the knee while restricting the varus valgus or a rotational strain on the knee. The next one is a hinge knee brace. It allows unrestricted flexion and extension but prevents varus valgus movements. The third one is a kneecap, which can only provide compression without restricting the movement. The fourth one is a stiff brace, and the figure below is a cast, and these generally completely immobilize the limb. So knowing the correct use of each is essential, as one cannot substitute for the other. Once the nature of injury is established and appropriate initial management is done, the patient needs to be reassessed regularly to note the progress. This is done by noting the improvement or deterioration of symptoms and repeating the clinical examination. Persistent large effusions with muscle wasting, inability to bear weight, restriction of range of motion or locking, and unstable knee are an indication that the injury may require either surgery or a prolonged rehabilitation. The further course of management needs to be decided at this stage in consultation with the patient. Let me cover some general principles that decide a definitive management. Generally, a conservative or a non-surgical approach is taken for the following situations. In cases of ligament sprains, partial tears, or meniscal injuries in the red zone, or muscle strains, or conditions like chondromalacia patellae or fat pad inflammation or bursal inflammations, generally a conservative approach is taken. Conservative approach is also taken when there is contraindications to the surgery or if the patient is unwilling to undergo a surgery. In these cases, where conservative approach is decided, we progress to appropriate rehabilitation as per the injury pattern after the initial management. The detailed rehab in each scenario shall be covered in subsequent weeks of this course. Now let us look at situations where surgery is required. Cases of tendon, capsule, or collateral ligament tears or avulsions are generally managed by either the repair of the substance of the tear or reattachment if they are avulsed along with the bony fragment. The cruciate ligament tears or bony avulsions are generally reconstructed either arthroscopically or open, as generally repairs of cruciate ligaments do not heal. They can be fixed back to their attachment in case of bony avulsions. The meniscal injuries generally require either arthroscopic repair or meniscectomy. Loose bodies require arthroscopic removal, and cartilage or osteochondral injuries may require debridement or refixation of a loose fragment. Wherever repair or refixation is indicated, it is essential to do it early, that is, within 7 to 10 days of injury when the initial inflammation has settled. If it is delayed, the tissues retract and fibrose, which will not allow for repair or refixation of these tissues. Generally, ligament reconstructions or meniscectomy are done as elective procedures after a trial of rehabilitation and if symptoms of instability or pain persist. The non-surgical approach generally involves first aid and symptomatic treatment followed by early rehabilitation shown in these slides, as these aspects will be covered later. Let's now see the indications for surgical management of each entity. First, the ligament injuries. For ACL tears, simple sprains or partial tears are generally managed conservatively, whereas a bony avulsion or complete rupture with persistent instability requires a surgical management. And whenever ACL tears are associated with meniscal or chondral injuries, again a surgery is preferred over a conservative management. The PCL tears are generally managed conservatively initially. However, whenever there is functional instability which is disabling, or there are combined ligament injuries, or if there is a avulsion of this from the bone, then a surgical approach is preferred. For collateral ligament, that is medial and lateral collateral ligament injuries, isolated tears are generally again managed conservatively, but failure of conservative treatment or combined injuries or avulsions may require a surgery. Posterolateral corner injuries generally cause significant instability since they are combined injuries and hence they are better managed surgically. Next are the meniscal injuries. Meniscus has a huge role in joint preservation, hence repairs are preferred over removal. The bucket handle tear or meniscal root generally require surgical repairs. In complex tears or irreparable tears, meniscectomy may be resorted to. Next are the patellofemoral injuries. A MPFL tear causing recurrent patellar dislocation and patellar and quadriceps tendon injuries, especially a complete rupture, usually require early repair or reconstruction. Other indications for surgical management of knee injuries include large osteochondral fragments or loose bodies causing mechanical block, or failure of non-operative management with persistence of pain, instability, or functional limitation, or in high-demand athletes who require early return to sport, surgical option may be resorted to. The next slide shows the management of bony avulsions of lateral collateral ligament and the posterolateral capsule being managed by early repair and refixation back to its native attachment. The next slide shows a refixation of ACL avulse from tibial spine. The next slide shows options for surgical management of various types of meniscal injuries. The bucket handle and the longitudinal tears are generally repaired, especially the tears in the red-white or the red-red zone definitely need to be repaired rather than a meniscectomy. For meniscal root tears, a transosseous repair is generally required. For a radial tear, the portion of radial tear which is in white zone may be removed by meniscectomy, while the portion of the radial tear which is in either red-white or the red-red zone can be repaired. Complex tears are generally irreparable. Hence, a meniscal balancing or a partial or sometimes a subtotal or total meniscectomy may also be required. The next slide shows arthroscopic picture of a displaced bucket handle tear of meniscus. And as you can see, this displaced structure has been reduced back to its original position, and you can see the repair in place. As we have discussed earlier, cruciate ligaments usually cannot heal by repair, and they generally require a reconstruction. This next slide shows the graft options for ligament reconstructions. Usually, an ipsilateral hamstring or a bone patellar tendon bone graft is used. However, nowadays, The peroneus longus tendon is becoming popular. These are all autografts since they are taken from the same patient. However, these autografts carry their own morbidity. Hence, allografts have been promoted for such cases, and allografts are generally of cadaveric origin. The next slide depicts ACL reconstruction, wherein you can see the tunnels in the tibia and in the femur, which have been drilled near the native attachment sites of the ligament. The graft is passed through these tunnels and fixed popularly using implants like endobuttons or interference screw. As you can see in the X-ray, you can probably see a endobutton on the femoral side. However, the interference screw is not visible. This is because most of these are bioabsorbable and cannot be seen on an X-ray. With increasing sports participation, young children who are not skeletally mature are also suffering from ligamentous injuries. And this slide shows how a pediatric ACL reconstruction is done. You can see that the tunnels in femur and tibia have been carefully drilled in order to avoid crossing the growth plate or the physis. You would be knowing that if you damage the growth plate or the physis, it may lead to growth disturbances in these children, which can cause either deformities or stunting of growth in that limb. Hence, such a procedure is done to spare the physis. The next slide shows how the repair of the quadriceps tendon is done. A mid-substance tear is repaired using sutures. However, when there is a quadriceps avulsion from the bony attachment from the superior pole of patella, it is to be refixed to the patella through transosseous sutures. A similar repair can be done for the patellar tendon as well. MPFL repair also is done for tears in the medial patellofemoral ligaments. Finally, after any surgery or conservative management, comes the role of rehabilitation. The steps followed in rehabilitation are shown in this slide. Rehabilitation is a prolonged and a deliberate process. It progresses through various stages or phases in order to reach the pre-injury level of fitness. Of course, since this course is about rehabilitation of sports injuries, we will be covering each and every step in great detail in subsequent weeks. With this, I have concluded the lecture and we come to the end of the first week of our course. To summarize today's lecture, I have covered the initial first aid that is to be started after an acute injury and how bracing and splinting promotes healing. I have then covered the definitive management of the sports injury, both conservative as well as surgical. I have then briefly touched upon the commonly done surgeries in various situations, and finally, how to progress through the rehabilitation following definitive management. Thank you and Jai Hind.